Hello and welcome back to Expert Perspectives from the 2014 Great Debates and Updates in Hematologic Malignancies meeting once again here in New York City. So this afternoon I'm talking with Dr. John Leonard, who is our lymphoma chair. John is from the Weill Cornell Medical Center here in New York City. So John, thanks so much for taking time to be with us.
It's great to be here, and thanks for organizing really a great meeting. It's a pleasure to be here.
Well, it's always a fun meeting. We always have some lively debates and interesting presentations, and we try to cover areas that are controversial, but yet clinically very important. And I think one of the topics that fits that criteria is how to manage patients with follicular lymphoma who have advanced disease but are kind of intermediate as far as their risk. Their FLIPI score is, should these patients receive standard R-CHOP or R-bendamustine, or should they get something that is a little easier, hopefully, like the R-squared regimen or another biologic doublet? And Myron Chuchman and Owen O'Connor debated that topic today. So give us a little background about that subject, and and what the arguments were, and what your feeling is about it.
Sure. So I think people in practice really recognize that when they see a patient with follicular lymphoma, they have two questions. One is, do you need to treat this patient now or not? And then the second question is, well, if you're going to treat them, what are you going to treat them with? And for someone who really has a substantial amount of disease, a substantial risk, you really generally have been thinking about chemoimmunotherapy. And in the rituximab era, the patient who is symptomatic and has significant disease is really someone who historically was treated with RCVP or R-CHOP. Now, in addition to R-CHOP, we've kind of moved largely away from RCVP to R-bendamustine. And so we have a couple of different studies, studies from Germany, another study led by Ian Flynn here in the US, the BRIGHT study, basically suggesting that R-CHOP and R-bendamustine are fairly comparable in efficacy, perhaps a little bit different in toxicity, mostly alopecia. And so our debate today really was around the issue of those two chemoimmunotherapy regimens versus, in this patient population, can we use a non-chemotherapy based regimen even though the patient needs treatment? Perhaps single agent rituximab is not enough for patients with more disease, higher risk features. And so are we at a point with the lenalidomide rituximab regimen that we can use that as part of an upfront treatment? And as you mentioned, the relevant study is a large international trial that is going on really around the world, randomizing patients to rituximab and lenalidomide versus rituximab and chemotherapy, either CHOP or bendamustine. And that's really based on data generated from a couple of different groups, partly in the relapse setting and now in the upfront setting, data from the MD Anderson group and Nathan Fowler, data from the Alliance CLGB led by Peter Martin, suggesting that rituximab and lenalidomide can be highly effective. And so now we're ready to do the big study, and that's ongoing. And our debate was really centered around where we stand today with that information. And we've got a lot of good data with this combination biologic doublet, the rituximab-lenalidomide regimen. So I think it's very, very promising. Obviously, we need to do the study, but I think it's really changing how we think about the disease, and gives patients other options that allows them to potentially avoid chemotherapy or delay chemotherapy. And at the end of the day, the debate will be settled by what the trials show.
Absolutely. So, well, another area that seems very controversial in follicular lymphoma is maintenance. So whether patients start off with low volume disease and get rituximab alone, or whether they get chemoimmunotherapy, whether or not they should stay on rituximab. There are a bunch of trials out there looking at the whole question of rituximab maintenance. So tell us what the argument is, and what the data shows, and what you do.
Sure. So this is an area, and I think in the history of this meeting, we've often had debates on maintenance because it's one of those things that people in practice need to know about. It comes up very commonly when I speak to patients. It's always the first question I get in a patient education forum is, should I do maintenance for rituximab or not in follicular lymphoma? So it really is something people need to know the latest on as the data evolve. So we have the PRIMA study that took patients that largely received R-CHOP or R-CVP, but mostly R-CHOP, and were in remission either with a CR or PR, randomized them to maintenance rituximab for 2 years or observation, showing an improvement in progression-free survival. However, no difference in overall survival. So that's really the big catch. PFS has traditionally been our endpoint in follicular lymphoma, an important endpoint. Waiting for overall survival can take a long time. PFS for patients seems good, that people like to be in remission, doctors like to keep their patients in remission, but at the end of the day, if you don't have an overall survival benefit, it makes the PFS benefit in a disease like follicular lymphoma perhaps not as compelling, and leads some people to question whether or not maintenance is really needed. And I think what's also called it into question a little bit is the RESORT study led by ECOG and Brad Call, that showed that basically, and that was another topic of our debate today, more or less, in patients getting single-agent rituximab and responding, looking at a maintenance regimen versus a retreatment regimen at the time of progression, and basically showing that the mileage you got out of rituximab was the same, whether you did a maintenance regimen or a retreatment. So I think it's gives us a lot of flexibility. I think those that believe in maintenance and scenarios where maintenance is helpful, mainly from the patient's perspective and their attitude to the disease and what their disease is doing, I think is perfectly reasonable to do. On the other hand, it says that if you don't want to do maintenance, it's okay, because you're going to get, in many of those patients who don't get maintenance and relapse, excuse me, many of those patients will go on to get rituximab when they have a relapse and can do quite well at that period of time. So in my practice, I'm pretty flexible. I explain the data to the patient, and some of them say, you know, I'm tired of seeing you, I'm happy to have the break, and I won't do maintenance. And others say, you know, staying in remission sounds better, I'll go ahead and do it. And so I try to have an honest discussion. I think in the lymphoma world, those of us who are designing trials, it calls into question, what's our endpoint? And ideally, in the absence of an overall survival benefit, perhaps PFS isn't the best endpoint. And what we really would like to have is a robust quality of life, because at the end of the day, the patient's living longer, they're feeling better. And does PFS really translate into feeling better, better quality of life? On the surface, it may. On the other hand, many patients, as everyone knows, can do well with follicular lymphoma, even though their disease is slowly progressing.
So in your practice, are there patients, you know, such as those who are very slow to get their PR, or whose PR is an okay PR, is a 55% as opposed to a 95% PR? Are those the sort of patients that you might lean towards continuation treatment as opposed to just observation?
I would say that that's tended to be my practice, that patients that I'm trying to squeeze a little bit more out of the rituximab regimen, that I'll give more of the drug. Now, and those that have a CR, in some ways you've achieved your goal. I'm not sure that that's the smartest thing to do, however, because if you achieve a CR, say with rituximab, that tells you it's working really well. Giving more of something that worked really well would potentially work even better. So it's somewhat illogical sometimes how we approach it, but I think really it's the patient that for instance, gets single-agent rituximab, gets a mediocre response, but you really want to kind of buy them more time before they have to get chemotherapy. That's somebody who may benefit from the maintenance, in my view.
Good. Well, let's go on and talk about one of the debates that you were involved in diffuse large B-cell lymphoma, and then we'll talk about Myron Chuchman's presentation on antibodies and antibody drug conjugates. So in diffuse large B-cell lymphoma, we know that genomically and by microarray, diffuse large B-cell can be divided into a germinal center B-cell and the ABC type. And the ABC type does not seem to do as well. And the question is, should you look at this and should you type patients and then plan treatment based on whether they're GCB or ABC? So tell us about the arguments and where you think where things stand as far as molecular characterization of diffuse large B-cell lymphoma. And you can hit a little bit on MYC positive patients as well.
Sure. So this is a very hot area in large cell lymphoma, in part because we seem to be having drugs that target one subset or the other. And it's fine to be able to say, look, you're going to do less well or better, but it's more important to have a drug that can actually do something about that, and we're getting there, which is encouraging. So the first question is, can you identify these two cell of origin subtypes, the germinal center and the non-germinal center, or the germinal center and activated B cell or ABC subtype to be specific? And the challenge there is that in routine practice, we can't do that in a robust way. We have immunohistochemistry markers, and there are a variety of criteria that people are familiar with, such as the Hans criteria, a way to go down an algorithm and look at the staining pattern and say this is more likely to be germinal center or not germinal center. The problem is, to use this in practice, it has to be robust. My pathologist and your pathologist have to be on the same page at doing this. It has to be something you can do in a timely fashion. A large cell lymphoma patient isn't going to wait around for a month waiting for their gene expression profile to come back. So the challenge for the field, in my view, is to develop a tool to be able to accurately subtype the patient in a robust way, in a time-efficient way. And that's something we focused on in the debate, because being able to use this now is really contingent upon that. And I don't really think we're quite there yet, but we're getting there. The second thing is then, what do we do about it? And do we treat patients differently? And we've got very intriguing data with 3 drugs, I would say, suggesting that in the non-germinal center or activated B-cell subtype, there could be an advantage to incorporating these drugs into therapy. And these drugs are bortezomib, and our group had done some initial studies there. We have ibrutinib, the Bruton's tyrosine kinase inhibitor, and we have lenalidomide. All 3 of those drugs have some data that they might have value in the activated B-cell subtype. And so the way to answer the question is to do randomized trials, where you're giving R-CHOP in a randomized fashion in this population versus R-CHOP plus the additional drug. And so those trials are ongoing. The initial studies are quite encouraging, but I don't think they're quite ready for people in practice to use. Now, you touched on the other scenario that is important when we talk about subtyping large cell lymphoma, and well, actually there are 2. One is the mediastinal lymphoma, where some are using, based on Wyndham-Wilson's data, our EPOC. We didn't really get into that in our debate, but I think that's something people should be familiar with in practice. The other is the MYC positive, or the double hit lymphomas, and that's a group that traditionally has not done as well with R-CHOP. And the question is, what should you do beyond R-CHOP? We have studies with our EPOC, we have some small experiences with transplant, we have some with hyper-CVAD, but we really haven't defined how we treat those double hit or MYC positive lymphomas in a way that really we can say this is the right treatment. The theory is more is probably better, but we haven't really yet backed that up with data. And again, identifying who is that subpopulation of patients remains a challenge. So I think it's really interaction with our pathologists and getting them to come up with a way to robustly define these populations is going to be key to moving forward.
Very good. So tell us a little bit about Myron Chuchman's presentation on monoclonal antibodies, and what are the most important targets for these antibodies, and then some of the novel agents that are being developed, especially the antibody drug conjugates. We've already heard a lot about brentuximab vedotin, but there are some additional agents in the works.
That's right. So as the audience, I'm sure, knows, Myron has focused for decades in his career on antibody-based therapy, and gave a very nice review of some of the new antibodies that are moving through clinical trials and now currently available. So we have ofatumumab, a human anti-CD20. We have obinutuzumab, also a human anti-CD20. Those are approved for CLL and are making their way into practice. And so the idea that a novel anti-CD20 that has been tweaked in one way or another to potentially kill tumor cells better, whether it's ADCC, complement, higher dose, longer treatment regimen, all of those things seem to be translating at least into CLL, and we'll see as they move into the other lymphoma subtypes how they have an impact. We have had some anti-CD22 based immunoconjugates. Our group had done some work with naked or unlabeled anti-CD22, but that's an internalized antibody. And we had a compound in clinical trials that with a chemo conjugate that unfortunately didn't really advance through in aggressive lymphoma. And then now we have a number of other immunoconjugates against CD19 or CD22 in clinical trials. And I think these are very exciting drugs. Myron gave us some overview of these agents. They've had some interesting toxicities, such as ocular toxicity in some case, which seems to relate to the immunoconjugate moiety. But it's good to see that, like in Hodgkin's, like in breast cancer, which the audience is familiar with, we have some of these agents that are making their way through the hematologic malignancies. And I think we'll see where they pan out in the clinical trials that are moving forward.
Very good. John, thank you so much. This has been helpful. I hope it's helpful to all of our viewers at home. And I just want to remind everybody that this year's Great Debates and Updates meeting is being taped, and it will be webcast in about 6 to 8 weeks. So you can certainly look for that and take your pick and watch whichever presentations you're most interested in. We appreciate your viewing these expert perspectives, and I hope next year you'll decide to come to the meeting. Thanks again.